Data and Methodology. Part 2, Defining Geographic Areas.
Geographic definitions of communities. The simplest and most practical way to define communities for healthy aging data reports is to use the jurisdictional boundaries of cities and towns, and perhaps neighborhoods within large cities. However, when secondary health data sources such as the BRFSS are considered, the issue is not so simple. In the forthcoming slides, we examine the factors that ought to be considered and explain how geographic communities were defined for reporting healthy aging indicators. The first factor we want to consider is population homogeneity. Smaller, relatively homogeneous geographic areas are desirable because residential neighborhoods are commonly characterized by a high degree of segmentation by socioeconomic status and race. It's common to see high-income neighborhoods with high-income households, lower-income neighborhoods with lower-income households, and even middle-income neighborhoods with middle-income households. What's not so common are neighborhoods where there's a mixture of high-income households and low-income households. Similar observations can be made about racial composition. Why is this an issue? When you have large geographic areas, you're more likely to have sub-areas which are very different from each other in terms of the population living there. You're likely to have higher SES sub-areas with better health status, along with lower SES areas with worse health status in the same large geographic area. What this does is, when you compute indicators for the larger geographic area, is end up averaging the data for healthy parts with relatively less healthy parts, coming up with some average health status area that can't be distinguished really from a homogeneous geographic area where the residents tend to be actually average health status. The second factor we want to look at is sample size. Larger sample sizes are desirable to estimate population health indicators. For that reason, larger geographic areas are desirable because you have more people living there. Larger data samples will be more reliable. Population averages are less sensitive to unusual outlier values contributed by a small number of residents. Also, with larger data samples, changes in health indicators over time are more likely to reflect real trends rather than random sampling variation. Can a single set of geographic communities be defined that have both of these desirable features? The answer is probably not. It's not generally possible because of the size distribution of cities and towns, and also the relatively small number of respondents in most health surveys. If one considers most states within the country, there are generally only a handful of larger, more densely populated cities in any state, and many, many more smaller, more sparsely populated towns. Second, most health surveys have relatively few respondents living in any particular city or town. If one considers the BRFSS, for example, there were fewer than 800 respondents from Manchester who were 60 years or older in 3 years of the survey data. How do you balance the goals of homogeneous geographic areas with the sample size limitations of secondary data sources? The approach we have taken we call multiple nested tiers of indicators in geographic communities. The tiers will depend on the sample size of the data source overall and the prevalence rate of the outcome indicator being measured. Generally, indicators will be estimated for larger geographic areas when the data sources have relatively small sample sizes and when the outcomes are relatively rare among older persons, for example, HIV diagnosis. By increasing the size of the geographic area, one increases the sample size in most data sets. And when one increases the geographic area for a relatively rare outcome, there are more individuals in the larger geographic area that may have that relatively rare outcome. The nested tiers approach. 3 points should be understood. First of all, small lower tier towns are spatially nested within larger higher tier geographic areas. Second, subsets of indicators are estimated using different geographic areas. Some indicators are estimated for individual towns. Other indicators are estimated for larger geographic areas. The third point I want to make is very important to understand. The same values of higher tier indicators, which are estimated for larger geographic areas, are reported for all of the smaller constituent towns that make up those larger, higher tier geographic areas. We believe that this nested approach offers a practical approach that balances the benefits of small geographic areas and homogeneous populations with the realities of limited secondary data sources. In the next series of slides, we describe the nested tiers approach in more detail. The hierarchical structure of the nested tiers approach is shown in this slide. In the example shown here, there are 4 tiers. Tier 1 is the lowest tier, and it's made up of 6 individual towns. Tier 2 is the next level of the hierarchy. It's the first higher tier. It's made up of 4 areas, area 1 through 4. The nesting is evident by noticing that area 1 of tier 2 is made up of town 1 and town 2. Area 2 is made up of town 3. Town 3 was not combined with any other town to form area 2. If one looks at area 3 of tier 2, that's made up of towns 4 and town 5. And likewise, area 4 is identical to town 6. So tier 2 is made up of 4 geographic areas. Tier 3 is the next level of the hierarchy, and I call them, in this example, region 1 and region 2. And you can see that region 1 is made up of 2 tier 2 areas, area 1 and area 2. And if one works backwards logically, region 1 is made up of towns 1, 2, and 3. Region 2, made up of tier 2 areas 3 and 4, is made up of 3 tier 1 areas, towns 4, 5, and 6. The highest tier in this scheme here is tier 4, and I call it Greater Region 1. It's made up of regions 1 and 2, and if one works logically backward, Greater Region 1 is made up of the 6 tier 1 towns shown on the diagram. This slide displays 4 real tiers that were defined for the Healthy Aging Indicator Study. Tier 1, the lowest tier, there were 244 individual cities, towns, and neighborhoods. All American Community Service indicators, ACS indicators, were Tier 1 indicators. Tier 2, we call them Medicare high prevalence geographic areas. These were indicators derived from the Medicare beneficiary summary file, and they are defined as higher prevalence indicators such as diabetes, COPD, osteoporosis. Those are Tier 2 indicators. Now those 154 areas were derived by combining together some of the 244 towns and cities of Tier 1. For Tier 3, there were 69 what we call Medicare low prevalence geographic areas. These were indicators derived from the Medicare beneficiary summary file, but they're conditions which are much lower prevalence than, let's say, diabetes and hypertension. They include things like personality disorders, bipolar disorders, colorectal cancer. Those are 3 examples of Tier 3 indicators. Now remember that the 69 low prevalence geographic areas were formed by combining together some of the Tier 2 Medicare high prevalence geographic areas together. Tier 4, the highest tier shown here, are the 28 BRFSS geographic areas. These areas were used for estimating indicators derived from behavioral risk factor surveillance system data. Now, if you recall, these are the health behaviors and health screening indicators. Given the hierarchical structure of the defined geographic tiers, all Tier 1 cities, towns, and neighborhoods, which make up a higher tier geographic area, are assigned the same indicator estimate for higher tiered indicators. The next 3 slides display hypothetical examples of this reporting approach. In this example, all Tier 1 communities that are nested within the same Tier 4 area have the same Tier 4 indicator value reported. So in this example, Tier 4 indicator is estimated to be 38.5%. All 6 Tier 1 towns receive the same 38.5% value for that indicator. All Tier 1 communities nested within the same Tier 3 area have the same Tier 3 indicator value reported. Okay, in this example, the Tier 3 has 2 regions. Region 1 is estimated to be, for this indicator, 42.2%, and towns 1, 2, and 3 all receive the same 42.2% estimate for that Tier 3 indicator. Likewise, Region 2 of Tier 3, its estimate is 17.3%, and towns 4, 5, and 6 all receive the same estimate of 17.3%. All Tier 1 communities nested within Tier 2 areas have the same Tier 2 indicator value reported. In this example here, Area 1 of Tier 2 has an estimate of 12.7%. The 2 towns which make up Area 1 both receive the same 12.7% value for that indicator. Likewise, Area 4, which is made up of towns 4 and 5, towns 4 and 5 both receive the same 14.1% Tier 2 estimate.
The end of part 2. Thank you.